I think it's about time, right?
Yeah, Mr. Chairman, you may start now.
Okay. Ladies and gentlemen, thank you for Professor Lin to organize this APS-SC for the adult congenital heart disease. And I think we have a lot of the good speaker experts from all of the Asia, including the Indonesia, Thailand, Mainland, then Taiwan. And my co-chair is Professor Baba, right? And he is from the Kyoto University. So let's start this program. This program is the issue to in management adult with adult congenital heart. So I think go ahead.
Should I talk?
Sure.
Okay. So this is Robaba, and first I'll present annotation. Adult with anatomic or physiological moderate or complex congenital heart disease ACHD benefits from multidisciplinary team care in collaboration with ACHD cardiologists. In the ACC, AHA, HRS, and ISACHD SCAI Guideline 2025 scopes are to encompass pathophysiology and surgical repair of palliation and progression of outcome on structural cardiac abnormalities present before birth and surviving to adult. In the present session, we dive deep in the management of congenital shunt, ASD, VSD, PDA, AVSD in adults, management of arrhythmia issues in congenital right-sided lesion, including Ebstein anomaly, TOF, and primary atresia in adults, management of congenital left side lesion, COA, congenital mitral valve stenosis, or triatriatum, supra of sub-valvalar aortic stenosis in adult, management of congenital coronary artery abnormality, AOCA, ACAPA in adult, management of the congenital complex lesion of adult, including d-TGA or CCTGA, and management of congenital complex lesion of DORV, trunks arteriosus, and Eisenmenger syndrome in adult. So the details and educative lectures by ACHD specialists, all cardiologists, and allied health professionals will refresh and upgrade in the multidisciplinary team's care of adults with congenital heart disease. Okay. So we have two chairs and two moderators, okay? And I am Shiro Baba from Japan, Kyoto University. And another is Dr. Yi Shan-sen from Taiwan, okay?
Yes, I'm Yi Xiangchen from Taiwan.
So how do we say the first three presenter I will present? Is that okay?
Yes.
Okay. So before the presentation, we just a moment. Okay, there is a disclaimer, and I'll show disclaimer. The content of this webinar is copyrighted by the ASPC, IPSC, and should not be distributed without a prior permission of APSC. The views and options expressed in the webinar are those of the faculty members and do not necessarily represent those of the APSC. Okay. Okay. Shall we start?
Yes, go ahead.
Okay. The first speaker from Vietnam, Hanoi, Dr. Nguyen Nhat Quan, Dr. Nguyen Nhat Quan, and he presents management of congenital shunt lesion of adults, including ASD, VSD, AVSD, and PDL, issue of PAH and shunt closure. Okay, please.
Thank you very much, Chairman. I would like. So, do you see my screen now?
Yes.
First of all, thank you very much to the organizing committee and APSC to let me talk about the one topic about the management of the congenital shunt lesion in adult. And in my talk, we try to discuss about the issue of the pulmonary artery hypertension and shunt close. I have no conflict of interest. So as you can see here in congenital heart disease in adult, we can divide it based on the anatomy and physiology state. And here you can see today we just talking about the simple lesion mentioned, meaning that we're talking about the ASD, PDA, VSD, and something in this area. And even this is very simple, but along the run, when we have a very big left to shunt drive, it can easily to cause the endothelium dysfunction, increase the pulmonary vein resistance, and after that become like Eisenmenger syndrome. So that's why when we're talking, discussing about the whole thing, we need to discuss about the first lesion until the end, meaning like Eisenmenger syndrome. So usually when we're talking about this type of disease, the main principle going to for shunt closing in this one is try to eliminate the cardiac chamber volume overload. Second is a reverse pathology. Yeah. Do you hear me now?
Yes, please go ahead.
So we're just talking about the principal goal of shunt close in adult. The first one to eliminate the cardiac chamber volume overload. Second one to reverse pathology chamber remodeling. The third one is the prevention of the pulmonary artery hypertension. And the fourth one is to prevent some very specific lesion complication. For example, like for ASD, we mentioned about the paradoxical embolism or atrial arrhythmia. For the VSD, we mentioned about the aortic regurgitation or the other one regurgitation. For the other part, like a PDA, we mentioned also about the effective endocarditis. So this is something like the main goal of the shunt close in the congenital heart disease in adult, and also to improve the symptom and functional capacity. And you can see here the data from the registry, Danish registry, quite a big one, showing that if you close the ASD, then the survivals become near normal. Another data showing that, this is another data showing that if you closing the ASD shunt, the outcome and survival actually the same. So when we're talking about the shunt closure, we mentioned a few things, and only one thing you mentioned here is to prevent the pulmonary artery hypertension. But however, this part is a really big issue, especially in developing country, when the patient got late detection. So that's why usually the patient came with the congenital heart disease and pulmonary artery hypertension. So by definition, the pulmonary artery hypertension is meaning like a mean pulmonary artery pressure more than 20 mmHg at rest, the resistance more than 2 Wood unit, and the pulmonary artery weight less than 15 mmHg. So we can see here, if we classify the pulmonary hypertension in congenital heart disease into the few group, and this one is become like a group 1. And in this one, we can see some subtype. The type 1 is Eisenmenger syndrome. The type B is the patient still got a very high systemic to pulmonary shunt. The third one is co-coincidental defect with the elevated pulmonary vascular resistance. And the last one, the type 4, is a post-correlation defect with the elevated pulmonary vascular resistance. So in this one, when we mention about the shunt close, we need to thinking about the pulmonary artery hypertension. Basically, for the indication and contraindication for the shunt closing, you can see here, it is from the the guideline from ESC 2020 and from the AHA 2018. You can see here, if the patient got very good big shunt from the left to right shunt, QPQS ratio more than 1.5, and then the pulmonary vascular resistance less than 3 unit, then you should close. Another approach in the AHA and ICC 2018, based on not based on the exact value, but also based on the ratio between the pressure and resistance of the systolic compared to the pulmonary. However, in 2025, the new guidelines got some similar thing, and everything now become using this similar unit. For example, like this is the new guideline for the ASD, and if the pulmonary vein resistance less than 3 unit in the ESC guideline or 2 unit in the AHA guideline, then you should close that. If the patient got something like a significant left to the right shunt, LV dilatation, and we have something like a moderate to severe pulmonary artery hypertension, then you can consider do some tests to choose the best way to close the shunt. And if the pulmonary resistance is very high, a patient got the asymmetrical syndrome, and then there is a contraindication for the shunt close. So this is a diagram came from the ACC and AHA guideline 2025. You can see here, based on the pulmonary vein vascular resistance, and you choose the close or not. And if the patient got a moderate to the high pulmonary artery hypertension, then you can classify a few things, and you can see how the patient adapt with the treatment before you close the shunt. So this is something like we mentioned here is the strategy we call like a treat and repair in the patient with the moderate to the severe pulmonary artery hypertension. So we can see here the patient is more than 5 unit of the pulmonary vein resistance. Then you treat it with the drug to reduce pulmonary artery hypertension, and after that we try to close that. And if the patient got some reduce of the pulmonary artery hypertension after you treat it with the targeted drug, then you can close that. So this is the summary for that. And 80% of the patient with ASD or VSD with a moderate to severe pulmonary artery hypertension can close. And after the close, the outcome actually is very good. So you can see here the survival in the repair group is better compared to the unrepaired group. And the variable to help you to predict the success after the treat and repair strategy is initial low pulmonary vascular resistance, low mean pulmonary artery pressure, QPQS more than 1, and saturation more than 90%. So this is something like the predictor to show that the treatment is good. So that's why now in the new guideline, the ASD closure is got a class 2B indication. And if the patient got and another situation like if you can have another situation like if the patient got a little bit like a high than moderate the pulmonary artery pressure, then you can combine like a fenestration device. So this is something show you the reason when you combine the fenestration closure device with the targeted medical therapy. So we can see here, we make the hole in the device, it closes, and after 3 months or 1 year, actually the outcome is good. The symptom is improved. The dysfunction of the LV and RV is improved. So this is something like showing that in some situation you can choose between the two strategies. The first strategy is using the drug and close completely with the device. And another strategy is fenestration device. So this is a meta-analysis, summarize the 10 study with a small number of patients, more than 200 patients. So we can see that if the patient got the severe pulmonary artery hypertension, you can choose like a two-test strategy. First one is treat and repair strategy. And if the patient is got some improve with the drug, then you can close. And if the patient have not improved by the drug, you can do like a two test, balloon occlusion test or vasoreaction test to see how the patient adapt with the close, and you can choose the penetration close. So in this situation, actually you can close us and improve the outcome. So this is some like a scenario when we propose algorithm for ASD with the severe pulmonary artery hypertension. If the pulmonary vascular from 3 to 5, then you can do like complete close. If more than 5, and after you treated with the pulmonary artery hypertension therapy, and the vascular improve, reduce to less than 5, then you can choose like a finesse close. Or if the patient don't have adaptation with the treatment, then there is no close for that. Or another situation, like if the patient got the LV diastolic dysfunction, then you can have like close like penetration to avoid the decompensate later on. So here there's something like a summary to discuss about the role for extra test for the test using like a acute vasoreactive test and the balloon test inclusion to make sure that you can choose the suitable candidate for the closed the shunt. However, for the adult, usually like a vasoreactive test is not recommended. And also the balloon test inclusion, usually like the most usefully for the adult patient when you try to identify the LV dysfunction before you close. And if there is something like a LV dysfunction, you should not close completely. You should using like a penetration device. However, one more thing is important here is the risk of the pulmonary artery hypertension is never zero after the shunt close. Even you close in the group of the young patient, patient age less than 25, then still got some cumulative risk of the pulmonary artery hypertension later on. You can see here, this is a data from the Big Hit registry. The cumulative incidence is about 2% and actually up into the 50% at the 15-year follow-up. And here really something like a predictor to predict the develop the pulmonary artery hypertension or persistent pulmonary artery hypertension after the shunt close. You can see here based on the anatomic defect, the some old age of the repair, the sex, the unexplained symptom, and some clinical finding. For example, like some variable, the hemodynamic variable, stress, or at the exercise. So how about the treatment of the pulmonary artery hypertension after shunt close? You can see here, if the patient still got the pulmonary artery hypertension post-close, then the survival outcome is low compared to the SMNger, because actually the SMNger got some the escape way to avoid the decompensate after that. So the treatment actually is similar to the pulmonary idiopathic pulmonary artery hypertension, and you can see here we can usually using like a combination between the endothelium receptor agonism combined with the PDE5 inhibitor. The last group we want to mention here is to management with the patient with the Ebstein syndrome, and usually you should use the single monotherapy or combine and slowly titrate with the similar to the pulmonary artery hypertension. But however, there is a few things different compared to the idiopathic pulmonary artery hypertension. First of all, is not the upfront combination therapy, just because we have a very limited data. So usually we use monotherapy first, and then second combination, usually using the combination between the endothelium receptor aneurysm with the PDE5 inhibitor. Second one is usually for asymmetric patient got a very fragile balance within the pulmonary and the systemic system. So that's why you need to close monitor the SpO2. The first one is not the routinely recommended for anticoagulation because none of the group has improved the survival and only reasonable in the patient with a history of the thromboembolic event. The next one is usually the atrial arrhythmias is emergency for the patient because it's easily to cause rapid deterioration of the cardiac output. So that's why you should do the cardiac cardioversion as soon as possible. So for the future, for the direction for the pulmonary artery hypertension related to the shunt, there is a 5 pillar. You can see here, the first one is novel anti-remodeling drug. Second one is innovative intervention strategy, especially like a reverse post shunt or penetration close. The third one is gene therapy to restore the genes BMPR2. And the second one, the fourth one is precision medicine, using the molecular mechanism to reclassify the pulmonary hypertension and individualize the treatment. And the last one, using the AI in early diagnosis for that one. So this is a future for the shunt-related pulmonary artery hypertension. And this is, to conclusion, the chairman and ladies and gentlemen, and I think that the shunt for the congenital heart disease in the adult is really a double-edged sword. In early stage, the shunt causes pulmonary artery hypertension, but in the late stage, the shunt actually protects the LV by acting the pressure relief valve. So that's why the early shunt close can prevent the pulmonary artery hypertension. But when the pulmonary vascular disease has formed, then you should be careful and follow up and treatment with the pulmonary artery hypertension tachytherapy. We discussed about the treat and repair strategy and may extend the intervention window for the gray zone. Long times ago, we don't dare to close that, but now we have some tests and the device to close that. And the last one is be very cautious with the pulmonary artery pressure after the shunt close. And this is my talk. And thank you very much for your kind attention and hope to see you soon.
Thank you very much, Dr. Guyenak. So we have a couple of minutes, and anyone do anyone have a question? No. So I have a question. Is that okay?
Yeah, please.
Okay. So before closing the ASD, you mentioned about mostly ASD closure, and before closing ASD, the patient who has a high PVR, you have to try the pH medicine. Is that okay?
Yes. So basically, we one thing here is based on the pulmonary vascular resistance, and if it is like less than 3, then we just close it. From 3 to 5, then we can consider closes. More than 5, then there is 2 options. One option is you treat it with the drug first, and if the pulmonary vein resistance reduce, then you can close it completely. And if the pulmonary vein vascular resistance is reduced but not very much, then you should consider like you close partially by the device with the penetrated. You can do it like on the table. You can make a hole, or you can use the device with already with the hole there. So up to you. Actually, the device is we normally use a normal device for ASD closer, and we make a hole there. And after that, we can follow up the patient and see what was going on. Yeah.
Okay, thank you very much. So if the patient has very high PVR, even after the administration of pH medicine, do you stop the pH medicine for these patients?
No, I don't think so. So in this situation, because somehow the treatment of the pulmonary artery hypertension can improve the outcome for the patient. So so based on the other variable, for example, like we usually like using like a 6-minute walking distance to measure the improvement of the capacity of the patient. the functional capacity of the patient. And in this situation, if the patient's got some improvement of that, I will continue the treatment.
Okay, thank you very much. Any other questions? Okay, so we'll move to next speaker. Next
Thank you.
speaker is Dr. Shen Nao Chao from Taiwan. That pronunciation is good?
Shen Chu. Yeah,
Chu.
thank you.
Zunnan
Shen Nan Chu.
Yeah, thank you.
Chu.
Okay, so please.
Okay, so I cannot share my. Oh, wait a moment. Okay, can you see the slide now?
Yes.
Yeah. Good afternoon, everyone. Thanks for Chairman introduction. Today I will discuss about the management of congenital right side lesion in adult congenital heart disease, and focusing on the ventricular tachycardia and the sudden cardiac death. Today I will talk about the Ebstein, tetralogy, valvular PS, PIVS, and the RV2PA conduit lesion. With the improvement of the long-term outcome in congenital heart disease, arrhythmia has become a major driver of outcome. In this population-based study of more than 11,000 adults, nearly 20% of patients had either an arrhythmia as baseline or developed arrhythmia over a 5-year period. Among them, tachyarrhythmia, especially ventricular arrhythmia, is one of the major and the most critical one to determine the clinical outcome. Ventricular tachycardia was associated with 1.3-fold higher hospitalization rate and more than twofold increase in mortality rate. And in this patient, historically, sudden cardiac death accounts for about 15 to 26% of late deaths in congenital heart disease. However, the arrhythmia landscape in this adult congenital heart disease patient is multifactorial and multidimensional. This matrix shows that the incidence of atrial arrhythmia, bradyarrhythmia, ventricular arrhythmia, and the sudden cardiac death. And we can see the type of arrhythmia depends strongly on the underlying anatomy and the previous operation. TOF is particularly associated with sustained ventricular tachycardia and the sudden cardiac death, whereas Ebstein anomaly combine the exit pathway and will cause the AVRT, atrial arrhythmia, and the ventricular arrhythmia. Therefore, lesion-specific anatomy must guide both surveillance and the treatment. The arrhythmogenic substrate is created by the interaction of the congenital anatomy, surgery, and the lifelong hemodynamic stress. Incision, patch, and the suture line form fixed barrier. Stenosis, pressure overload, and the volume overload, ischemia contribute to the ventricular hypertrophy, dilatation, and the fibrosis. Over time, this process creates slow conduction and the respiration heterogeneity. This result may be macro reentry, arrhythmia around surgical obstacle, focal or micro reentry tachycardia, or pulmonary VT and ventricular fibrillation in more diffuse myocardial disease. For practical purpose, ventricular arrhythmia substrate can be divided into two overlying groups. Group A has decreased anatomical micro reentry barrier. They support a monomorphic micro reentry VT. Repair tetralogy follow is a prototype of this subtype. Group B had a diffuse myocardial disease with focal or micro reentry scar related substrate and will promote the polymorphic VT and the ventricular fibrillation genesis. Ebstein anomaly is included here. These categories are useful, but there are still some overlap, and they become less distinct as the patient age grew older. Then we see the TOF first. TOF was a prototype of ventricular arrhythmia in congenital heart disease and was studied extensively in recent 20 years. Long-term survival after TOF repair is excellent, but the hazard ratio is not constant over time. In our cohort, Annual mortality rate was approximately 0.12% during the first 15 years follow-up. However, it decreased to 0.39 annual mortality rate after 15 years after the operation. Therefore, the death acceleration of death is consistent with other large cohort. Morbidity and mortality begin to rise in the third decade, where sustained arrhythmia, heart failure, and sudden cardiac arrest emerge. Risks of sudden cardiac death in repair TOF are multidimensional. Traditional markers including previous shunt operation, ventriculotomy scar, these hemodynamic factors are very important. However, the electrophysiologic factors like the QRS duration prolonged and the non-sustained VT are also common risk factors of that sudden cardiac death. In this ICD cohort, the highest rate of appropriate therapy occur with elevated LVEDP, non-sustained VT, and a ventriculotomy incision scar. No single variable is sufficient to predict the late sudden cardiac death. And how to management of the ventricular arrhythmia in this repair TOF patient. There are three parallel components. First, to correct the hemodynamic lesion, that the pulmonary valve, including the surgical and transcatheter pulmonary valve replacement, to avoid pulmonary regurgitation and ventricular dilatation and dead ventricular dysfunction. Then ICD implantation, and the criteria may be secondary prevention or primary prevention. Then catheter ablation of ventricular tachycardia substrate using either 3D mapping and a surgical operation. As 30 years ago, Dr. Cardonis have proposed a mechanical electrical interaction in TOF patient, and he hint out the importance of the pulmonary regurgitation on the ventricular arrhythmia. So to correct the pulmonary regurgitation has become more and more important and more recognized. And PVR was done more and more, and now there are several kinds have suggested the PVR even in asymptomatic patients. And if they have the enlarged RV volume overload or RV dysfunction or QRS duration prolonged. Whether the correction of PR truly associated with improved outcome, let's see the indicator registry. Among more than 1,000 eligible patients with repair TOF, using the propensity match score and the full cohort analysis, both show that the association between the PVR and the 59% low risk of death or sudden cardiac death, and all sustained VT. The patient benefit was greatest when RV and systolic volume index exceeds 80. This observation evidence support the intervening before irreversible mechanical electrical cardiomyopathy develops. In the 2024 HA guideline, they propose a broader framework. First, confirm the relevant RVOT dysfunction in symptomatic patients. One major criteria may justify to consider the PVR. If the patient is asymptomatic, 2 or more criteria are suggested. And the criteria included here is the indicator risk score, including RVF, LVEF, peak O2 consumption, and RV systolic overload. If there are sustained VT or other arrhythmia, then EP was consulted and the ablation or ICD should be considered in these patients. Then let's move to the ventricular tachycardia. In 10 years ago, Dr. Mo JP have suggested anatomical isthmus as arrhythmia substrate in repair TOF. He suggests 4 common isthmus, including the isthmus 1 between RV incision patch and the pulmonary annulus. Isthmus and the trachyval or VSD patch. Isthmus 2 consists between the incision patch and the pulmonary annulus. Isthmus 3 between the pulmonary annulus and the VSD patch, and the isthmus 4 between the VSD patch and the trachea valve. And he suggested these 4 critical isthmus may be the most important substrate of ventricular tachycardia. And in the past, when surgical PVR is planned, surgeon can perform the cryoablation to connect the relevant anatomical barrier at the time of surgery for these 4 common isthmus. In nowadays, it is still performed in some centers and guided by pre-OP, EP mapping and guidance. However, not every anatomical isthmus is arrhythmogenic. The key functional marker is slow conduction. In the study by different field, a conduction velocity below 0.5 meter per second was strongly associated with clinical or inducible VT. And then now we can use the 3D mapping to integrate the voltage, activation, and anatomy to know the conduction velocity to identify the slow conducting anatomical isthmus. Across several studies, the isthmus 3 was the dominant target of the ventricular arrhythmia. And this is real-world data. The recent French nationwide study illustrates the contemporary practice. More than 1,000 catheter ablation procedure, 200 and more than 200 patients was due to ventricular arrhythmia, and 126 were ventricular arrhythmia ablation in TOF patients. Group A, he divided the patient into Group A and the Group B. The Group A is, I just mentioned, the macro reentry related tachycardia, and the Group B more related to the diffuse myocardial disease and the ventricular fibrillation or polymorphic VT dominant. And we can see the Group A has higher successful rate compared to the Group B and the lower recurrence rate compared to Group B patients. And the success rate was high during the ablation. However, the recurrence rate is still not very satisfactory. The acute success rate was around 86% for all cohort, but recurrence rate was 18% in a 1.2 years follow-up. For TOF with clinical VT, the acute success rate is also the similar 87%, and the recurrence rate is still not low. So, in addition to an anatomical isthmus theory, reparation heterogeneity may be another important mechanism. The pulmonary regurgitation or RV dilatation will increase the reparation heterogeneity, and the PVR alone may not eliminate established scar or slow conduction. So in this situation, anti-arrhythmia drugs have limited protective evidence. And in this situation, ICD implantation is still necessary when there is decreased reparation reserve to prevent sudden cardiac death. And in the DAF T4F registry from French, appropriate therapy occur at approximate 12% per year in secondary prevention group and 7% per year in primary prevention group. So we can see the ICD prevention is effective and very important in this adult congenital heart disease patient. At the same time, device-related complications still accumulate, including infection, inappropriate shock, and disc dysfunction. Therefore, the secondary prevention indications are very clear because the appropriate shock rate is far exceeds the complication rate. However, the primary prevention decision requires careful risk assessment and the discussion of the lifetime device consequence. So another important issue in nowadays is for repair TOF with clinical unstable VT, should we perform the catheter ablation alone or we need the ICD implantation? For the repair TOF with unstable VT or resuscitated sudden cardiac arrest, it is still a class 1 indication for secondary prevention. And primary prevention is considered when multiple sudden cardiac death risk factors are present. However, catheter ablation in the patient with a subgroup With the normal heart function, only one ventricular tachycardia isthmus, and after ablation have bidirectional block and no inducibility. In this subgroup, should we perform the ICD implantation? It is still controversial. So in this subgroup, the ICD implantation is still controversial, and recently in 2026 APHRS, there will be a debate about this issue. And then we talk about the surgical and transcatheter PVR. In the past, surgical PVR is the only choice, but with evolving technique, more and more transcatheter PVR has been implanted. This is especially suitable to cases with suitable anatomy, especially in patients with high surgical risk and multiple previous stenotomy. New self-expanding systems have expanded transcatheter PVR to large native or patch alveolar tract, making EP planning even more important. This is because once a transcatheter valve has been implanted, it will cover the alveolar tract, and then will access to isthmus 3 and sometimes isthmus 2 will become limited. The metal frame can prevent consider contact with the critical myocardium. Therefore, the most reliable strategy is to identify and treat a slow conducting or inducible substrate before valve implantation. So the strategy for the pre-PVR ablation before the transcatheter PVR implantation has been proposed. This creates a clear workflow here. Before PVR, estimate arrhythmia risk and decide whether invasive EP test is appropriate. During the EP study, we have to map the potential anatomical isthmus, test inducibility, and ablate the clinical relevant slow conducting isthmus. If isthmus 3 cannot be blocked from the catheter approach, then we should consider surgical PVR with cryoablation. If it can be successfully ablated, then we can go forward to the transcatheter PVR. The goal is to establish the bidirectional block before a transcatheter PVR will permanently cover the ablation target. In a study by Dr. Moore in UCLA, inducible VT, pump ablation, and insulated patient ICD therapy. Patients with isolated slow conducting anatomical isthmus also underwent substrate modification by transcatheter approach. In contrast, when no inducible VT or slow conducting isthmus, then we should reassuring a follow-up course after valve implantation in this subgroup. Okay, so after we see the TOF patient, then we see the Group A, other Group A congenital heart disease, the variant of the coronal truncal topography. The same principle extends beyond classical TOF, but the corridor change with anatomy and repair. In valvular PS, isthmus 2 may remain intact, but because there is no transannular patch, in dual RV, VSD location and relevant to both outflow tract determine the conduction corridor. In TOF with pulmonary atresia, RV to PA conduit and the extensive scar will obscure and eliminate the standard isthmus. Mapping must therefore be anatomical specific. Then we move to a Group B congenital heart disease. I will talk about the Ebstein anomaly first. Ebstein anomaly combined with the abnormal valve anatomy with the myopathy right ventricle, apical displacement of the tracheal valve create an atrial scene and often fibrotic RV, where severe regurgitation promote progressive chamber dilatation. And in this situation, early presentation may be dominated by precipitation and AVRT, while ventricular fibrosis and myocardial dysfunction become increasingly relevant later in life. And in addition, surgery will change the VT substrate in Ebstein anomaly. In unoperated patient, focal or micro reentry tachycardia often localized to the atrial, that is RV. After valve replacement or repair, reported VT more often arises from the global scarred myocardium of the Purkinje system. Therefore, the mechanism observed after surgery may not reflect the preoperative substrate. So, before tricuspid valve surgery, patients with precipitation, documented tachycardia, or concerning symptoms should undergo EP assessment. X-ray pathway should be mapped and ablated before the surgical anatomy limits catheter access. Imaging and mapping may also identify a arrhythmogenic region in the atrial, that is RV. Finally, ventricular arrhythmia substrate is not static. In young group A patients, decreased isthmus-related monomorphic VT predominant, while aging, fibrosis, ventricular dysfunction, and heart failure increase, and even group A lesion may acquire a diffuse substrate, similar to the group B. In group B, diffuse myocardial disease and the related risk of pulmonary VT or ventricular fibrillation become more prominent with elder age. This is why risk assessment must be repeated throughout life rather than assigned one. So here I will make a brief conclusion and the take-home message here. Ventricular arrhythmia are not uncommon in adult congenital heart disease patients and are the major determinant of mortality and hospitalization. Group A, the TO variant, have the micro reentry circuits rely on discrete anatomical instruments. ICD implantation may be necessary in most of the patients with spontaneous VT. Catheter ablation can be an alternative to ICD in selected patients, but achieving bilateral block is crucial. Transcatheter PVR has become the main treatment strategy, and the standard coverage of isthmus-3 mandate PVR EP study and prophylactic ablation necessary. For group B patient, diffuse substrate and SS pathway drive a polymorphic VT and VEF risk profile. The substrate and the clinical presentation of the ventricular arrhythmia may involve with advancing age. A multidisciplinary approach balancing hemodynamic, electrophysiological, and device therapy is essential for lifelong management. Thanks for your attention.
Thank you very much. We have a couple of minutes to have the questions. Any questions? So I have a question about ICD. That's okay?
Okay.
So in Japan, to implant ICD is very hard to say. It's a kind of difficult because in Japanese guideline, ICD is recommended to implant for the patient who experience a faint. Okay, so but in your presentation, it's better to do the to implant the ICD before the faint. It prevents a sudden cardiac death. Is that okay?
Yeah.
So how do you explain for the patient to implant the ICD before implantation of ICD?
So you just talk about in Japan the ICD implanted only for those with sudden cardiac arrest survivor, but for the patient with sustained VT, we may speculate that he will develop the sudden cardiac death in the future. Maybe this time he was successfully resuscitated, but or just symptomatic, but not the sudden cardiac arrest. But in this patient, this patient should be high risk group. So for the patient with sustained VT and the symptomatic, I still recommend the ICD implantation in this group. And whether we should implant the ICD in a patient with asymptomatic VT or non-sustained, maybe 20-second or 15-second VT, then there is still great debate here, because this non-sustained VT should be considered as the not the secondary prevention, by the primary prevention. So for the primary prevention, we should consider about how many risk factors he had. Did he have the ventricular dysfunction? Did he have the previous other high risk factor that increase LVTP, severe RV dilatation, or with plus the non-sudden VT or induced VT? So if he have multiple risk factor, then there are two approach now. One is then this patient should receive the IGD implantation. Another is we may consider ablation first. If ablation can successfully eliminate all the arrhythmia isthmus, then maybe ablation can be postponed later. However, there are still some debates here. In the guideline, they still suggest primary prevention in a multiple risk group. However, in Taiwan, like in Japan, we only support the secondary prevention. So we only implant patient with a spontaneous VT, aborted sudden cardiac arrest. But now we still, in some patients with inducible pulmonary VT, we still perform the ICD implantation for this patient.
Thank you very much. And I have another question. So about AP study, okay. Before transcath PVR, okay.
Yeah.
So before transcath PVR, do you perform all the patients for do you perform EP study for all the patients? For example, the patient who has only a how do I say, the patient who has a small number of PVC, okay, PVC in
PVC only have low burden of PVC.
yes.
Yeah.
So
Actually,
for this patient, you do the EP study before transcatheter PVR?
Actually, maybe since 5 years ago, we performed the EP study for all patients who will receive the transcatheter PVR. In addition to the Holter study and the other treadmill study, we do EP study. But I know in many European center or in the Northern American center, they perform not only EP study, but perform the 3D mapping to identify all anatomical isthmus and try to ablate them. And but in our center, we still we just only perform the EP to see the VT inducibility. If there is VT induced, either sudden or not sudden, then we will perform the 3D mapping to ablate the arrhythmia substrate. If the patient have no VT or VPC induced, then we just go ahead to the transcatheter PVR and follow up the patient. So we routine perform pre-PVR EP study, but not the 3D mapping for all of the case.
Okay, thank you very much. So now we have to move to next speakers, okay? So next speaker, Dr. Verapon Bimpanichakan, okay?
That's okay.
Verapon Bimpanichakan from Thailand. So she will talk about management of congenital left-sided lesion of adult, including collaboration of aortic congenital mitral valve stenosis and supravalvular and aortic stenosis, subaortic stenosis, and triatriatum, issues of recurrence and after surgery. Please.
Okay, thank you, Mr. Chairman, and I'm so honored to be here in this meeting. I would like to share my slide first. So my slide and my voice went well.
Okay.
Okay. Okay, you can hear me?
Yes.
Full screen, please.
Yeah. This is full screen. Do you see full screen?
Yeah, it's good.
Okay, so my talk is about management of congenital left side lesion in adult, and the theme is issues of recurrent after surgery. So we know that nowadays is successful of surgery for congenital heart disease. So more than 90% of children from peds come through adult clinic right now. So the question is, how do we manage the consequence over the next 50 years? So what is the late complications, and what about their surveillance, and what should we intervene when? When should we intervene, right? So I would start with the first lesion is coarctation. So post-repair coarctation, they're still at risk of vascular complication from aortic wall injury and the remodeling of the repairing site. So we expected the recoarctation, maybe not much, about 10%. And some case we have aneurysm. And the very important thing is the hypertension, because even with an excellent repair, half of the patients still have hypertension, maybe develop after that or persistent hypertension. And this is from the Swedish registry to see that this is almost 2,000 repair coarctation patient. You can see the free from recoarctation, the numbers quite well, 88% at 10 years, and still 85% at 30 to 50 years. And this slide is to compare post-surgery and post-catheter-based treatment. So you can see that post-surgery have a good number from free recoarctation, 15% compared to 35% post-catheterization. And the risk of recoarctation is complex surgery and the younger age at the repair. Sorry. So what we follow up for coarctation, I encourage you to do the four-limb blood pressure whenever a patient came to the clinic, because it's very easy, simple, and it's non-invasive things that we can do. And the blood pressure will tell you about the patient, tell you about the hypertension that patient have or not. And also you got arm-leg blood pressure gradient, and the gradient is tell you about the narrowing. And also we do the echocardiogram as well. For surveillance with imaging, in guidelines say that every 3 to 5 years, we should do the imaging. And this picture, you can see that with large aneurysm or small aneurysm, we can miss with the physical examination, right? We cannot do physical examination to see the aneurysm. So surveillance with the image is quite important. And we choose MRI, prefer MRI more than CT, because this is young patient and have a multiple image to follow up lifelong. And don't forget the bicuspid aortic valve, because we found that more than 60% involved with the coarctation and leads to aortopathy and increased morbidity and mortality in this patient. So when you consider to re-intervention, so if the post-repair cohort have a definition of significant coarctation, then you should consider the redo. So what is the definition of significant coarctation? So the arm-leg blood pressure gradient more than 20 millimercury. So that's the easy way we know that that coarctation come back again. And even if the patient have hypertension or evidence of LVH, that's quite confirmed. And you can see that the 20 millimercury from arm-leg blood pressure gradient can extrapolate to the mean Doppler gradient from echocardiogram and the peak-to-peak in the cath lab. And some patient, maybe you didn't got this gradient because they have a lot of collateral. Imaging can help you. We have the number of aortic isthmus ratio less than 0.5. And if you see a lot of collateral in the image, maybe that's indicate that have to do something with that coarctation. And if you pick up the one who need to do the re-intervention nowadays, we prefer the transcatheter treatment first with the balloon cover stent to prevent the aortic complication from open surgery. But the open surgery still have room in the complex anatomy and associated with aneurysm. So I would like to move to the next lesion, congenital mitral stenosis. There's a lot of pathology in this area. Parachute mitral valve, supramitral ring, double orifice mitral valve, and have to be careful that MS may be one of the many levels of left side obstruction in Cone complex. So this is data from Boston, 108 patients with severe congenital mitral stenosis that show the survival-free compared from post-balloon mitral valvuloplasty and survival-free from post-surgical mitral valvuloplasty. I would like you to see on the figure A first. You will see that the survival-free after balloon mitral valve is not quite well, with 55% at 1 year and dropped to 39% at 5 years. So the independent risk factor of this decreased survival is post-dilatation, moderate, and severe mitral regurgitation. So at the post-surgery part in the figure B, you will see the better number, but not quite well. Survival-free from post-surgical mitral valve annuloplasty is around 69% at 1 year and 5 year. But in the surgery, you have to see the heart block requiring pacemaker 7%. So let's say from that paper, congenital mitral stenosis subsequent surgery are common, and the 5-year survival is poor. So what we're looking for, the late problems, is restenosis, progressive of mitral regurgitation, and pulmonary hypertension. We found that most in patients with Cone complex and will lead to atrial fibrillation and RV dysfunction. So what we do in the clinic, we follow echocardiogram and the 12-lead ECG to detect the atrial fibrillation and other arrhythmia. In some patients, we do exercise testing. And for the threshold for reintervention, in the AHA guidelines say that we will use the number from the mitral valve disease in the valve guideline. So basically, we look at the mitral valve area, we look at the presence of atrial fibrillation and presence of pulmonary hypertension. So come to the subaortic stenosis. This is the 3 type of subaortic stenosis. So the type, this one, the left-hand side, the discrete aortic stenosis type, this tends to progress after surgery because the membrane can regrow. And for the third one, the diffuse tunnel, this one have a high rate of recurrence and worse long-term outcome compared to other 2 type because of the smaller aortic valve annulus. And the recurrent rate for a subaortic stenosis is around 25%, is quite high. Let's say reoperative rate 2% per year. And the high risk if the patient repair at the younger age, have small LVOT, short membrane to aortic valve distance. So late complication in this lesion, we expect the LVOT obstruction because when we remove the membrane, but the substrate is still there and the LVOT geometry is abnormal. We also expected for progressive aortic regurgitation and also the recurrence of the membrane. And many patients has heart block and iatrogenic VSD after surgery, so we have to look for that too. There is something they say about the surgical technique that with the myectomy combined with the membrane resection may have a lot of heart block. The risk of heart block is around 4 to 5%. That's required pacemaker. So they say that should not do routine myectomy if it's not indication. Just membrane resection is okay. And this is data from multi-center cohort study from Europe, from USA, and Canada. I want you to see on the left-hand side first, the cumulative survival from the post-membrane resection is 97% over 20 years, so the number is quite good. But when you see the intervention-free survival, the number dropped down because 26% in this group, at least they need 1 reoperation, and the reoperation rate is around 2% per year. And on your right-hand side, when we look at the gender, you see that the risk of reoperation in female is 1.5 times risk more than male because maybe they got smaller alveoli. And another risk factor that's very interesting is preoperative alveoli gradient more than 80 millimercury. And this next slide going to show you nicely that the preoperative alveoli gradient more than 80 millimercury is associated with moderate aortic regurgitation. And in your right-hand side, it's more obvious that if the preoperative alveoli hit 100 millimercury, the moderate aortic regurgitation is sky high after 2 years follow-up. So we can say that pre-op alveoli gradient more than 80 millimercury is an independent risk factor for developed moderate AR post-op. So what we're looking for the patient with post-surgery in subaortic stenosis, sure, we do the echocardiogram. And if the patient need plan for surgery, maybe you need more detail for it, like TEE or 3D or imaging. And the threshold gradient that you need to consider redo from the 2025 AHA guideline is more than 50 millimercury of maximum pressure gradient. And also if the patient have significant aortic regurgitation, like moderate or severe progressive, the AR may be redo needed. And also, if the patient have symptom of heart failure and ischemic symptoms or LV dysfunction, maybe you need to consider redo surgery. On your right-hand side is a number from ESC guideline 2020. I just put it in for, you can compare it. So we move to the supravalvular aortic stenosis. The reoperative is quite high too, is 25% for follow-up 25 years. And mostly because of the restenosis of the supra area of the aortic valve or the aortic regurgitation, or sometimes from PA restenosis, especially in the Williams syndrome. So other late complication that significant and we have to look for is the coronary artery disease, because we know that with the supravalvular AS, there's a pressure in this picture. See, the pressure is hit the coronary artery. So this problem keep the adult have the high risk for sudden cardiac death and coronary artery disease in the long term. This is a study from Netherlands with post-operative supravalvular AS followed for 13 years. I would like you to see the number of 10-year survival is quite good at 83%. But when we look at the operative group compared to unoperative group, you'll see that unoperative group have better 10-year survival at 87% compared to 79% in operative group. And when we look at the cardiovascular events, you'll see that in operative group, there's a lot of arrhythmic events, especially atrial fibrillation, followed by heart failure and coronary events. So what is increased risk for a late mortality and reintervention for a supravalve AS is a concomitant alveoli obstruction and the surgery at very young age, like under 1 year, because small native valve and Williams syndrome, because in this syndrome, the entire arterial tree is non-compliant, so it's more morbidity and mortality. And most even occur first in 10 or 15 years after surgery. I would like to touch a bit about the surgical technique in supravalvular AS. There is single patch on your left-hand side, 2 patch in the middle, and 3 patch. And for a quick, I do the table to compare the freedom from reoperation. You'll see that the 3 patch technique have the best outcome, with free from reoperation 88 to 100% at 10 years. Compared to single patch, the number is 50 to 60% free from reoperation at 10 years. So we do the echo to follow the gradient, and we do the imaging to see the restenosis and aneurysm. and also the coronary artery problem. So we have to maybe do the coronary CT to see the anatomy of the coronary, especially if the patient came with chest pain or some ischemic symptoms. And the threshold for the redo in supravalve AS is the mean Doppler gradient more than 40 millimercury. This is from ESC 2020 guideline. So come to the last lesion is triatriatum. This is the best excellent prognosis. With after-membrane resection, there is rare recurrence, but some adults may face residual membrane, and the unique problem is pulmonary vein obstruction, so it's lead to AF. We follow up with echo is okay for cotri. And this is staged in AHA 2018 guideline, quite nice and clear that in adults with prior repair triatriatum sinister and have recurrent symptoms, we should look and evaluate for the pulmonary vein stenosis. For the number for resection is mean membrane gradient more than 15 millimercury. This is a threshold that we should do the surgery. And this sentence is staged in the 2025 AHA ACHD guideline, and I love this statement. It feels so good and impressed. So they say that triatriatum to date, no instances of recurrent membrane obstruction after intracardiac repair have been reported. So it's quite nice lesion. And this is a summary from 5 lesions that I talked today, what come back and what kills the patient. Start with coarctation, we expected recoarctation, and what kills the patient is hypertension that we have to look for, and the aortopathy. For sub-valve aortic stenosis, we expect for the membrane regrowth, and what kills the patient is the progressive of the valve aortic regurgitation and lead to the LV dysfunction. For supravalvular aortic stenosis, we have to look for the alveoli obstruction, and what kills the patient is the coronary artery disease. And for congenital mitral stenosis, we look for the valve obstruction and the mitral regurgitation, and we have to be careful of pulmonary hypertension. For triatriatum, there's rare recurrent and have the excellent outcome. I would like to end my talk with this slide. So the repair is not a cure, and then this patient need a lifelong surveillance. So us as an adult congenital heart cardiologist, our role is to anticipate, not simply react to the late complications. Thank you very much.
Thank you very much. Very good talk. And
Thank you.
anyone, do anyone have the questions?
I have a question. Did you
Okay,
hear me?
Dr. Chan.
Sure.
I'm very surprised that the supra-aortic stenosis in adult patient, the operated patient has the poor result than the unoperated patient. So you may suggest us we do not perform the procedure for the patient with the supra-aortic stenosis in adult or in adolescents.
Actually, when I saw that data, is quite surprised though, like the supravalve, why the operation look not so good. But in that detail, because of the operative group have other lesion in a complex, so maybe
Maybe
that's
the reason.
Yes, that's a reason.
And by the way, about the 3-patch, there are some technology. Operation technology such as the 3-patch. My personally like to cut because for the supra-aortic stenosis there are some problem in the coronary artery because of high pressure. There are some calcify or not calcify, a stenotic change in the artery. So I would like to cut the bottom roof of the artery to enlarge the whole coronary artery. It becomes more wide open of the coronary floor. Since once the supra-aortic stenosis will release, the pressure will drop to the coronary artery. So we must wide open of the coronary artery. Is my personal experience.
Yeah, that's the good one, the 3-patch. They said with expertise. Yeah. Thank you so much for the comment.
And I have another question about the congenital MS. I believe it is a very difficult question. Since for pediatric, sometimes it's very difficult to wide open the mitral orifice. But because the evolution of technology or the operating technology, there are some procedures such as Congenital procedure. You may try this procedure for the congenital MS with the congenital aortic stenosis. Once you perform the Congenital procedure, the mitral valve size and the aortic valve size was decided by the surgeon. You can as big as you can, especially for the adult patient. But for the pediatric, it's still a problem. Okay, it's my comment.
Thank you for the comment. Thank you so much.
Any others? So I have a question. Is that okay?
Yes, okay.
So you talk about left side stenosis, mostly stenosis, and the left side stenosis is sometimes life-threatening. Life-threatening, okay?
Sorry, again.
Left side
Life-threatening.
stenosis, life stenosis, threatening.
Life-threatening. Left side.
Critical.
Stenosis, yes.
Okay. So the patient who has a moderate stenosis will mainly progress to the severe state.
Yeah.
And thinking about this, if you have the patient who has a moderate stenosis, how do you think about the early intervention toward this stenosis before the recommendation of guideline?
If that not touch the threshold to redo or like that.
Either way. Either way. Yeah.
Actually, for me, the symptoms of the patient is the first that I concern. So we have to talk about the symptom of the patient and the number from the echocardiogram or even other investigation. So if they're not met the number to redo, or the patient is high risk or something, maybe use the medication, like if the tachycardia or have AF, rapid ventricular response, or LV dysfunction, maybe use GDMT first and close follow-up and interval, the echo follow-up more frequent. Yeah.
Okay, thank you very much.
You're welcome. Thank you.
Any others? Okay. So Dr. Chen will take over chairs from next speakers. Okay.
Thank you, Professor Papa. And we have the next speaker, Dr. Okatava Lilasari. He will talk about the coronary congenital coronary artery abnormality. Dr. Lilasari, please.
Thank you very much. You see my slide?
Yes.
Okay, thank you for this great opportunity. It is an honor for me to be here, and good afternoon, everyone. Today, I will discuss the management of congenital coronary artery anomalies in adults with a particular focus on risk stratification and multimodality imaging. Although relatively uncommon, these anomalies encompass a broad spectrum of conditions ranging in incidental finding to myocardial ischemia and sudden cardiac death. In this presentation, we will review their clinical significances and diagnosis approaches. So this is my presentation outline. First, it will begin with the background and classification of congenital coronary artery anomalies, and then we will then discuss the mechanism of ischemia and risk stratification. And next, we will review about anomalous aortic origin of coronary artery arising from the pulmonary artery, and coronary artery fistula. And finally, we will examine multimodality imaging and summarize the key take-home messages. So the normal coronary circulation consists of two main coronary arteries, First is the right coronary artery and the left main coronary artery. The RCA originates from the right coronary sinus, also known as the right sinus of Valsalva. While the left main coronary artery arises from the left coronary sinus or left sinus of Valsalva. And the left main coronary artery typically bifurcates into two major branches, the left anterior descending artery and the left circumflex artery. The ELED travels along the anterior interventricular groove and supplies the anterior wall and interventricular septum, while the LGX courses within the atrioventricular groove and supplies the lateral wall of the left ventricle. Congenital coronary artery anomalies are congenital abnormalities involving the origin of course of the coronary artery, and it is first described by Ogden et al. In 1969. Reported prevalence varies depending on the imaging modality used, and the accurate diagnosis requires appropriate imaging evaluation. Angelini classified coronary artery anomalies into anomalies of origin, course, and termination. Anomalies of origin include anomaly aortic origin coronary artery, Al-Kappa, R-Kappa, and single coronary artery. Anomalies of course include interarterial, intramural, retroaortic, prepulmonary, and intraseptal variants, while anomalies of termination include coronary fistula and atrioventricular malformation. Not all coronary artery anomalies are clinically significant. Our goal is to identify the high-risk anatomical features associated with myocardial ischemia and sudden cardiac death. The interarterial course has historically been considered the malignant course, but current evidence suggests that intramural segment is probably the most important determinant of ischemia. The key anatomical high-risk features include slit-like coronary ostium, interarterial course, intramural course, acute takeoff angle less than 45 degrees, and proximal narrowing with an elliptical vessel shape. These anatomical abnormalities can produce dynamic coronary compression during exercise, and the physiological consequences include stress-induced myocardial perfusion defect and patchy myocardial fibrosis, which provide a substrate for ventricular arrhythmia and sudden cardiac death. When interpreting CCTA, these are the specific features we should actively look for and report. The management of coronary artery anomaly began with confirming the diagnosis using non-invasive imaging, preferably CCTA or CMR, while echocardiography remains useful in younger patients. The next step is determine whether high-risk anatomical features are present. If high-risk anatomical is identified, patients undergo functional ischemia testing, preferably with exercise stress imaging. And patients with demonstrable ischemia are generally referred for surgical revascularization or anatomical correction. If ischemia testing is negative, management becomes individualized based on age, symptom, and the specific coronary anomaly. Patients over 35 years often require evaluation for concomitant coronary artery disease before attributing symptoms solely to the anomaly. So the key message is that anatomy alone is not enough. Clinical symptom and objective evidence of ischemia should give and guide management. Management of a symptomatic patient is more controversial because the balance between intervention and observation is less unclear. The first step remains detailed anatomical assessment with CCTA or CMR. Patients with left aortic origin anomaly and high-risk anatomy, particularly an interarterial or intramural course, generally warrant ischemia test and should be considered for surgical repair if ischemia is demonstrated. For the right AAOCA, management is usually more conservative because the overall risk of sudden cardiac death is substantially lower. Patients without high-risk anatomy generally require no restriction of physical activity. No single imaging modality can answer every clinical question in coronary artery anomalies. Transthoracic echocardiography is the first-line screening tool because it's widely available, inexpensive, and radiation-free. While coronary CT angiography has become the gold standard for anatomical characterization, it provides excellent spatial resolution and accurately defines the coronary origin, proximal course, relationship to the great vessel, and high-risk anatomical features. Cardiac MRI complements CT by assessing ventricular function, myocardial perfusion, ischemia, viability, and myocardial fibrosis without radiation exposure. Invasive coronary angiography, often combined with IVUS, is reserved for selected patients when additional anatomical detail or invasive treatment planning is required. Anomalous aortic origin of the coronary artery refers to one or more coronary artery arising from the wrong sinus of Valsalva. So AAOCA is the most clinically significant congenital coronary anomaly with the prevalence of 0.4 until 0.8%. The two major subtypes are left anomalous aortic origin of the coronary artery and right anomalous aortic origin of the coronary artery. Right anomalous aortic origin of the coronary artery is more common, whereas left anomalous aortic origin of the coronary artery carries a higher risk of myocardial ischemia and sudden cardiac death. The anomalies of coronary course could be pre-pulmonic, aortic, subpulmonic, and interarterial. EOCA includes various anatomical subtypes classified according to the involved coronary artery and its course. Interarterial and intramural course are considered high-risk features because of their association with myocardial ischemia and sudden cardiac death. While right anomaly aortic origin is more common, whereas left aortic anomaly origin is generally associated with greater clinical risk. So identifying the coronary course is essential for risk stratification and management. Echocardiography is the first-line modality for evaluating AAOCA. Important markers include an oblique coronary origin from the opposite sinus and acute angle takeoff. Color Doppler can identify an intramural course within the anterior aortic wall. An intraconal course runs within the conal septum below the pulmonary valve annulus. In this example, color Doppler demonstrates opposite flow direction in AOLCA and AAORCA. Coronary CT angiography is considered the gold standard for anatomical assessment of AOCA. Beyond confirming the anomalous coronary origin, CT allows comprehensive evaluation of the entire proximal coronary course and its relationship of the great vessel. More importantly, CT identifies anatomical features associated with myocardial ischemia and sudden cardiac death. The high-risk features include slit-like ostium, acute of angle less than 45 degrees, proximal hypoplasia or narrowing, intramural course within the aortic wall, elliptical or compressed coronary lumen, long intramural segment. These findings directly influence risk stratification and surgical decision-making. The images show demonstrated an anomalous RCA arising from the left sinus with the short intramural segment and proximal stenosis. Oblique axial and conventional volume render CT image clearly demonstrate anomalies origin of the RCA from the left aortic sinus with a short narrowing due to intramural course. On the transparent lumen volume render CT imaging compared to the normal origin of the LCA, the anomalous RCA origin show a pinpoint narrowing. And the left image show anomaly course of LCA arise from superior left coronary cuspid. Cardiac MRI evaluates coronary anatomy, ventricular function, and myocardial viability and fibrosis. And stress cardiac MRI is useful for detecting inducible myocardial ischemia and guiding risk stratification. While the abdomen stress cardiac MRI has demonstrated high feasibility and safety in pediatric patients. Today, CT and cardiac MRI have largely replaced invasive coronary angiography for the evaluation of coronary anomaly. Coronary angiography is mainly reserved for intervention or inconclusive non-invasive finding. IFUS, FFR, and IVR can assess the functional significance of coronary abnormalities. However, their use in children remains limited because of the need of sedation and potential complication. So coronary angiography remains the reference standard for divining coronary anatomy when non-invasive imaging is inconclusive. This table summarizes the strength and limitation of the main imaging modality used in anomaly aortic origin of coronary artery anomalies. Echocardiography is widely available and useful for initial screening, while CTA provides the best anatomical characterization. Cardiac MRI offers additional information on ventricular function, myocardial ischemia, and fibrosis. Nuclear imaging and invasive functional testing are mainly used to assess ischemia. Therefore, multimodality imaging is essential for accurate diagnosis and risk stratification. Next, I will move to discuss about coronary artery arising from pulmonary artery. In this anomaly, one or more coronary artery arise from the pulmonary artery instead of the aorta. Coronary artery rising from the pulmonary artery are extremely rare, occurring in approximately 0.01% of coronary angiography. The two main subtypes are Al-kappa and R-kappa, with Al-kappa being more common. The abnormal origin causes myocardial ischemia through the coronary still phenomenon. Al-kappa has two distinct clinical presentations depending on collateral development. During the neonatal period, pulmonary artery pressure is similar to systemic pressure. So antegrade perfusion through the left coronary artery is maintained. After pulmonary vascular resistance fall, perfusion pressure in the pulmonary artery decreased dramatically, and in infant type, there is a poor collateral formation. Blood preferential flow retrograde into the pulmonary artery. Severe left ventricle ischemia develops, and more than 90% mortality during the first year if untreated. While in adult type, extensive RCA to LCA collateral vessel develop, and myocardium survive, but chronic coronary still is persists. Patient remains at risk for ventricular arrhythmia and sudden cardiac death. Chest radiography finding differ between infant type and adult type Al-kappa. In infant type of Al-kappa, cardiomegaly commonly result from left ventricular and left atrial enlargement and may be accompanied by mild pulmonary edema. While in adult type of kappa, chest radiographers are often normal or no show only mild cardiomegaly with non-specific finding. In this image, the chest radiograph demonstrates cardiomegaly with enlargement of the posterior cardiac border and posterior displacement of the left main bronchus. Echocardiography is the first-line imaging modality for the diagnosis of Al-kappa, particularly in infants and children. Key findings include retrograde flow into the pulmonary artery, dilation of the right coronary artery, and extensive collateral vessel. Left ventricular dilation, systolic dysfunction, muscle dysfunction, and mitral regurgitation may also be present. And regional wall abnormalities may indicate myocardial ischemia or previous infarction. However, echocardiography has lower sensitivity in adults, and the coronary origin may be difficult to visualize. Therefore, CCTA or cardiac MRI is often required to confirm the diagnosis. Cardiac CT plays an important role in confirming coronary anatomy in patients with Al-kappa. In the infant type, cardiac CT may demonstrate the anomalous origin of coronary artery from the pulmonary artery, absence of collateral vessel, myocardial infarction, and ventricular dysfunction. But in contrast, the adult type is characterized by well-developed intercoronary and extracardiac collateral vessel. Adults usually have absent or only mild ventricular enlargement and hypertrophy. Cardiac MRI plays an important role in the evaluation of Al-Kappa, particularly in adult patients. However, in the infant type, MRI is generally not recommended because of its limited spatial resolution and longer time of examination. Therefore, for the children, CT is preferred. But in adults, MRI may demonstrate the anomalous coronary origin with retrograde flow into the pulmonary artery and well-developed intercoronary collateral. Cardiac MRI is also useful for assessing myocardial ischemia, infarction, and fibrosis. In addition, mitral regurgitation, ventricular enlargement, and hypertrophy are usually mild or absent in adult patients. Single MRI confirmed the anomalous origin of the left coronary artery from the pulmonary artery, and serial Cine images are also used to evaluate ventricular size and function, while left gadolinium enhancement demonstrates infarction in the anteroseptal wall. In the infant type of angiography, demonstrate drainage of the left coronary artery into the pulmonary artery with limited collateral circulation. In contrast, in the adult type, show markedly dilated coronary artery and prominent collateral vessel. And pulmonary angiography confirm retrograde flow from the coronary circulation into the left coronary artery. This is a case, a woman, 47 years old, who presented with exceptional chest pain for 2 years. The ECG was normal and there is no evidence of cardiomyopathy from the X-ray. Echocardiography shows preserved left ventricular systolic function with ejection of 60% and normal wall motion normal wall motion. And concentric left ventricle remodeling was present while diastolic function is remained normal, and cardiac valves and right ventricle contractility were preserved. The CCTA saw left coronary artery originated anomalies from the main pulmonary artery consistent with Al-Kappa. An extensive collateral circulation from the RCA was present with contrast reflux into the pulmonary artery. In addition, the coronary artery demonstrates aneurysm dilatation. While the coronary angiography demonstrates a single coronary ostium located anteriorly, the right coronary was dominant and markedly dilated. No significant stenosis or other abnormalities were identified. Other anomalies is single coronary artery. In this anomaly, this is uncommon congenital condition with a broad spectrum of anatomical configuration. Although many variants are clinically benign, some may carry a risk of ischemia and sudden cardiac death similar to anomaly of coronary artery origin. Several classification systems for single coronary artery has been proposed, with the Lipton classification being the most widely used. Lipton classified SCAI according to the coronary sinus of origin, either at the right or on the left, and the subsequent of anatomical courses. In group 1, the solitary vessel follow the normal course of RCA or LCA and continue to supply the contralateral coronary territory. In group 2, a large aberrant branch arises from the proximal segment and crosses the base of the heart through different pathways, anterior, interarterial, posterior, septal, or combined. In group 3, the LED and LCX originate separately from the proxima of RCA. These are some cases. At the right image, CTE volume renders images reveal 2 cases with an isolated left 1 type single coronary artery. The RCA vessel follow the normal course and RCA continue into the opposite territory. While at the left image, CT volume render images demonstrate an isolated right 1 type single coronary artery in 50-year-old man. The single coronary artery originates from the right aortic sinus and it courses along the right atrioventricular grooves, passes through the crux of the heart, and reaches the left atrioventricular grooves. Distally, the vessel continues as the left anterior descending artery. Next anomaly is a coronary artery fistula. It's an abnormal communication between a coronary artery and a cardiac chamber or great vessel by passing the myocardial capillary bed. The most common drainage site is a right ventricle, followed the right atrium and pulmonary artery. Drainage into the coronary sinus and left-sided chamber is less common. Clinical manifestation depend on the size of the fistula and its drainage site. Large fistula may result in the coronary steal phenomenon, leading to myocardial ischemia and the heart failure. The CT image shows a female, 28 years old, the coronary cameral fistula connecting the right coronary artery to the right atrium with obstruction at the sides of fistula drainage. So as a take-home message, congenital coronary artery anomaly present with a broad clinical spectrum ranging from incidental finding to myocardial ischemia and sudden cardiac death. And comprehensive evaluation require a multimodality imaging, including echocardiography, coronary CT, cardiac MRI, and invasive angiography. Risk stratification should integrate anatomically feature, ischemic burden, and clinical presentation. And management follow-up should be individualized and involve a multidisciplinary approach. Thank you very much for your kindly attention.
Okay, thank you, Lily. And she gave me an extensive review of the abnormal coronary artery disease in the adult heart. So the topic open for discussion. Any comment or any question for the audience? If not, could I ask a question about the AAOCA, the operation indication for the AAOCA for the left side? I think is important, but how about the right side?
Yeah, as I already mentioned, that the left side is a high risk compared with the right side, because at the left side it can be interarterial and intermural courses, so it can make a compression during the exercise, so it can cause the ischemia and also arrhythmia and sudden cardiac death. So that's why the left coronary artery AOCA is highly pay attention compared with the RRC.
And another question about the screening, since you say the incidence about 0.4% to 0.8% for the school patient, especially in the children or in the adolescents, they always complain that chest pain, there are some exercise intolerance. So is it recommended to perform the coronary angio CT routinely for the school patient, or just wait and see?
So for the adult patient, the first screening should be from EKG and also for the echocardiography. And if we have a suspicion of the other anomaly, coronary anomaly, so we can proceed to the cardiac CT. I think the cardiac CT is a gold standard for the coronary anatomy examination.
Okay, since the time is limited, is there any question? If not, we thank you.
Yes, can I ask one question, please?
Yes, please.
Yes, in pulmonary artery, pulmonary atresia with the intact ventricular septum, we commonly found sinusoid, a connection between the right ventricle and coronary artery. And we usually stated that it's right ventricle coronary, dependent coronary artery, yeah. But in fact, should we perform a coronary angiography to make sure that there is no stenosis or there is a stenosis of the proximal coronary arteries, because we usually didn't do that, and then we decide that it's danger to decompress the right ventricle, and we do a Fontan procedure. In fact, we should make sure that if there is no stenosis, then we can decompress simply the right ventricle with a biventricle repair or 1.5 repair. I would like the comment of all the speakers. Thank you.
Thank you very much for the question, Dr. Anna. Yes, I think it's very important to us for us to evaluate whether there is a RVDCC, especially to decide whether the anomaly can be biventricular repair or univentricular repair in the pulmonary atresia with intact ventricular septum. So first modality that can be used is echocardiography first, and then I think it's important for us to combine it with the coronary arrhythmography, yeah. So we can confident with the whether there is a RVDCC for this case or not, because I think if the it is not really shown at the echocardiography, we have to do the further examination to be performed, so we can see whether there is a RVDCC or not by angiography, cardiac catheterization.
Okay, we must jump to the next topic. We have the next speaker from Japan, Professor Yamamura. You will talk about the management of the congenital complex lesion, such as the TGA, CCTGA. Dr. Yamamura, please. Thank you.
Oh, thank you for your kind introduction. Just a moment, please. Okay. Can you see my slides?
Not yet. Okay. Okay.
Thank you. I'm Kenshiro Yamamura from Kyushu University Hospital, Fukuoka, Japan. Today, I'll talk about the management of adults with complex congenital heart disease, focusing on transposition of the great arteries, TGA, and congenital corrected transposition of the great arteries, CCTGA. I have no conflict of interest. For TGA, we have two surgical strategies: sending and muscle procedures, so-called atrial switch, the classical one, and recent adjacent procedure, so-called arterial switch. Atrial switch keeps the right ventricle systemic, so RV dysfunction and tricuspid regurgitation remains a problem. Arterial switch makes left ventricle systemic, so less long-time complications. For CCTGA, we have three surgical strategies. Physiological repair or conventional repair keeps the right ventricle systemic, so RV dysfunction and tricuspid regurgitation remains a problem. Anatomical repair, so-called double switch operation, makes the left ventricle systemic, but adds atrial switch problems. When biventricular repair is not possible, the Fontan procedure is chosen, and then, high venous pressure becomes the issue. First, a brief word about the arterial switch operation. These survivors have relatively few adult problems, but three checkpoints matter. First, the transferred coronary arteries. Rate of stenosis can be silent. Second, the neo-aortic root and valve. Because the pulmonary root is now systemic, aortic regurgitation is relatively common. Third, pulmonary artery stenosis after the Lecomte maneuver. Echo often underestimates it, so don't hesitate to use the CT or MRI. Next, TGA and CCTGA patients with the Fontan circulation. Most late problems come from the Fontan physiology itself, but I add 3 anatomy-based checkpoints. First, the systemic outflow pathway. A restricted BSD can become subaortic obstruction. Second, aortic regurgitation is relatively common in patients with Dems-case tonsil. Third, in CCTGA, AV block progresses. So we have to plan the pacing route in the complicated anatomy. Because the time is limited today, I'd like to focus on systemic right ventricle, the unique population in TGA and CCTGA. Two conditions result in systemic LV, TGA after thinning or mustard, and CCTGA after conventional repair or without surgery, natural cause. I will talk about clinical features, medical therapy, surgical therapy, and tips and clinical pitfalls about systemic LV. Let me start with clinical features. This is TGA after the thinning or mustard procedure. Blood flow is corrected at the atrial level, but the right ventricle remains systemic, as I mentioned before. So late problems are baffle stenosis in 5 to 20%, baffle leak in up to 50%, sinus node dysfunction in 40 to 6%, and atrial tachyarrhythmias in 15 to 50%. This is congenitally corrected transposition of the great arteries, CCTGA. Associated lesions are some lesions are present about in 90%, BSD in 60 to 80%, pulmonary stenosis in 30 to 50%, and tricuspid regurgitation, often Ebstein-like, and complete AV block develops at about 22% per year. So lifelong ECG monitoring is essential. The long-term prognosis is not so happy in systemic LV. This recent report followed muscle patients for up to 48 years. Survival was 61%, but event-free survival was only 14%. Heart failure occurred in 37%, and symptomatic arrhythmia in 39%. I call this the 40-year wall. Let me show a typical case. A 37-year-old man after the thinning procedure, the systemic right ventricle ejection fraction is only 18% with moderate tricuspid regurgitation. This is a problem in the long term in systemic LV. So why does the systemic LV fail? The first reason is muscle fiber structure. The left ventricle has 3 layers of helical fibers and makes an efficient twisting motion called torsion. The right ventricle has mainly longitudinal fibers. In the systemic right ventricle, torsion is almost lost and contraction becomes inefficient under high afterload. The second reason is coronary microvascular dysfunction. Oxygen demand rises because the ventricle works at a systemic pressure. But the right coronary artery was designed for low pressure ventricle, so supply cannot keep up. Capillary density falls and fibrosis progresses. The result is chronic ischemia and a vicious cycle. The third reason is tricuspid regurgitation. In CCTGA, the tricuspid valve often has Ebstein-like attachments. Regurgitation adds volume overload to a ventricle that already has pressure overload. Then the ventricle dilates, the annulus dilates, and the regurgitation becomes worse. Also, it's a vicious cycle. This figure summarizes the late problems in the 2 systemic LV groups. After thinning or mustard, baffle stenosis, baffle leaks, sinus node dysfunction, and atrial tachyarrhythmias. In CCTGA, BSD, pulmonary stenosis, tricuspid regurgitation, and AV block. One more important point. After thinning and mustard, stroke volume cannot increase enough during exercise because of the stiff atrial baffle route. Let's move to medical therapy. Now, let me talk about the critical options. This schematic review was prepared for the HA Guideline 2018. It included 6 studies and 202 patients treated with conventional heart failure drugs. The results were disappointing. Ejection fraction did not improve, and diastolic volume did not improve. And systolic volume did not improve, and peak oxygen uptake did not improve either. For many years, this field was called an evidence void. This study looked at real-world practice. 150 adults after thinning or muscle procedure with a median age of 30 years were followed for 8 years. In the whole group, RAS inhibitors and beta blockers did not change mortality, and the confidence intervals were wide. But in symptomatic patients, the hazard ratio was about 0.13 for RAS inhibitors and 0.12 for beta blockers. So these drugs may work when the disease is more advanced, we believe. In the last few years, the situation has completely changed. The 4 drugs established in the left heart failure, ARNI, beta blockers, MRA, and SGLT2 inhibitors are now being tested in the systemic right ventricle. This is a real turning point. SGLT2 inhibitors are the most interesting drug. Preload reduction, better myocardial energy metabolism, and antifibrotic action fit the pathophysiology of the systemic right ventricle, as I mentioned. DAPA-SERV improved fractional area change and longitudinal strain. A multicenter retrospective study showed about 70% fewer heart failure hospitalization. This is the DAPA-SLV trial published last year. 32 patients, 20 TGA and 12 CC-TGA received DAPA-free closings for 10 million per day. At 6 months, 6-minute walk distance and quality of life score improved significantly, and fractional area change rose from 28 to 33%. ARNI also induced reverse remodeling. In this prospective study, fractional area change improved from 29 to 35%, and 3-dimensional ejection fraction from 36 to 42%. 6-minute walk distance improved from 425 to 500 meters. In contrast, the classical Vanish trial with valsartan showed no improvements after 3 years. So recently, we shift from S inhibitors or ARB to ARNI if it is tolerated. Next, I will talk about surgery. Triatriatum regurgitation adds volume overload and accelerates ventricular failure, so the timing of surgery decides the prognosis. In this classic paper, when preoperative ejection fraction was 40% or more, function was maintained in 63% of the patients at 8 years. However, below ejection fraction 40%, only 10% kept function. Therefore, the ESC guideline recommended TBR while ejection fraction is 40% or more as class 1. So basically, do not wait for failure. However, if the ejection fraction is below 40%, is that hopeless? This slide showed TBR in patients with systemic RVEF below 40% in our institute. One patient has no previous cardiac surgery, and his NYHA function class was 1. The other 3 patients underwent cardiac surgery. In addition, 2 of 3 had been hospitalized for heart failure previously. 2 patients were complicated with complete AV block, and 1 of them was implanted with a DDD pacemaker. There are the volume data. All 4 patients had an ejection fraction between 31 and 37%. 2 had maxillary dilated ventricles with an end diastolic volume index over 220. Case 2 was assessed by cardiac CT because she had a pacemaker. This shows the medications before surgery. Guideline-directed medical therapy was limited, and 2 patients received no heart failure drugs at all. The bottom row shows the performed ablations. All 4 had tricuspid valve displacement, and 2 also had CRT procedures. And here's the result. After TBO, the NYHA functional class improved in all patients. Before surgery, 1 patient at class 3 and 2 at class 2. After surgery, all patients were class 1. BNP also decreased from about 235 to 49 picograms per milliliter. The p-value was 0.14 because the number is small, but the direction was the same in all cases. Next, device therapy. In the systemic right ventricle, right bundle branch block is the target for resynchronization, like left bundle branch block in the LV patients. The Japanese guideline gives class 2A for ejection fraction 35% or less, NYHA 2 to 4, and QRS duration 140 to 150. CRT is especially effective in pacing-induced dyssynchrony. For ICD, secondary prevention is class 1, you know. For primary prevention, we consider ICD for patients with syncope, non-sustainability, wide QRS, and severe tricuspid regurgitation. Let me show a pediatric case. An 8-year-old girl with CCTGA after VSD closure. She had a complete AV block and unlimited pacemaker implantation. The chest X-ray shows cardiomegaly, and the ECG, here's a wide QRS. This is the echocardiogram before the intervention. The systemic right ventricle is dilated, and the septal motion is clearly dysynchronous with the so-called swing motion. There's severe tricuspid as well. We change the pacing site to parahesian position intravenously. The QRS become narrow, and the BNP decreased from 264 to 46 picograms per millimeter. A girl in a wheelchair now come to the hospital with roller shoes. This is the echocardiogram after parahesian pacing. The septal motion is much better, and the ventricle is smaller. The severe tear improved to mild to moderate tear. She's now 25 years old, BNP is 92, and she's doing well about 70 years after the intervention. Early attention to dyssynchrony gives a long-term benefit. Lastly, I will talk about clinical tips and pitfalls. The last topic is an important pitfall, pulmonary hypertension after the stenting or massage procedure. In this study, post-capillary pulmonary hypertension was quite common in patients after stenting or massage procedure, and the prognosis in patients with pulmonary hypertension was clearly poor. This is often missed with echocardiogram. So when I was in Toronto, routine catheterization at the age of 40 was just started. In the same study, systemic hypertension and NYHA 3 to 4 were associated with pulmonary hypertension. So we should measure the blood pressure and treat hypertension if needed. This is our last case. A 38-year-old man with TGA after the massage procedure. He had a TV annuloplasty at 14 years old. At age 20, his catheter data were completely normal, with a mean pulmonary artery pressure of 12. He remained asymptomatic, started working, went overseas, and was lost to follow-up. At age 35, he developed atrial fibrillation and heart failure. Diuretics and ACE inhibitors were studied at the local hospital. Then he was referred to our institution. We performed anticoagulation and cardioversion first. Here is the catheter and MRI data. Mean pulmonary artery pressure was 64 millimeters of mercury, and pulmonary vascular resistance was 13 ordinates. ejection fraction was 22% with an endodiastolic volume of 440. He had severe post-capillary pulmonary hypertension. This is the treatment course. We used furosemide, rivaroxaban, and veprizole and performed cardioversion. Then we added bapafluprozin and repeated the catheter evaluations. Actually, d-DMT worked. Mean pulmonary artery pressure fell from 64 to 22 millimeters of mercury, and the pulmonary vascular resistance improved from 13 to 2 wood units, completely with a normal lesion. So in this case, pulmonary hypertension was reversible. MRI showed a clear reverse modeling as well, and diastolic volume decreased from 440 to 180 millimeters. Ejection fraction also improved from 22 to 30%, and BNP fell 179 to 11 picogram per milliliter within normal range. He underwent tricuspid valve replacement, CRTP implantation with epicardial leads, and a catheter ablation, including pulmonary vein isolation and tricuspid isthmus ablation. He is now doing well. So we believe d-DMT works even in systemic RV. The keys are MRI to measure EF and catheterization to evaluate pulmonary hypertensions. Monitor carefully and do not hesitate to start d-DMT and perform TBL. Let me summarize with 3 messages. First, medical therapy for the systemic RV was long considered to lack evidence, but SGLT2 inhibitors and ANI have changed the world. Second, tricuspid valve replacement is best performed when ejection fraction is above 40%, but below 40% is not without hope. Third, CRT should be considered even in right bundle branch block, and it is especially effective in paced patients. Thank you very much for your attention. I thank for all the excellent staff in our pediatric and adult congenital team. I'll be happy to take any questions. Thank you.
Okay, thank you, Professor Yamamura. Thank you for sharing the experience of the TGA and the d-TGA. Any question from the audience?
Okay, I have a question. It's okay?
Okay.
Thank you very much. Very good talk about RV failure, especially. And I have a question about SGLT2 inhibitor and ANI.
Yes.
For the RV failure, these two are a kind of effective for improving. How about how do you think about this idea to whether apply to the system RV type single ventricular phantom patient who has a very severe heart failure?
Oh, thank you for a very important question. Basically, I believe that it is also effective for single ventricle patients with the RV morphology. Actually, we have some experience in single ventricle patients who are responsive to d-DMT. So we usually start SGLT2 inhibitor first because it causes less hypertension. And if they tolerate, we add ANI from a small dose and a slow start.
Thank you very much.
Okay, thank you. Since the time limit, we will jump to the next topic. Next topic is presented by Professor Wang. He is the chairman of the cardiovascular surgeon in Taiwan. And he will talk about the congenital complex lesion in the DORV and the truncus. Professor Wang, please.
Could you hear me?
Yes.
Okay. I want to share my
Screen.
Is that work?
Not yet.
Not yet. Try it again. Did that work?
No.
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 How
You
to
should find there are some share.
I did.
Share under the shared PowerPoint. Show the PowerPoint.
Show the PowerPoint. I push it.
Yeah, it's coming. Please make a full screen.
Make the PowerPoint full screen.
The PowerPoint. We saw your PowerPoint, and then
Okay.
Okay. Please
Full screen.
make a full screen. Make a presentation mode.
Okay, it's okay. Okay now.
Okay.
Okay.
Okay. So today we
full screen.
Full screen.
No full screen. Your
Yes. That.
Is that okay?
not okay. Yeah, because we are still watching your. Would you please stop presentation and try again? Because we saw you have a different screen. Please share that presentation screen.
Yeah, I'll try it.
Please stop sharing and try again.
Stop sharing.
Yeah, try again.
Stop sharing.
Oh, let me try. Let me do it. Okay, can you do that?
Okay, I put down my PowerPoint again.
Yeah.
Okay.
Okay, make a full screen.
Yes.
Full screen.
Click that.
Is that okay?
And go up on the right left corner. 显示设定. Please swap because we're now watching two.
This one.
Swap. Okay. Yeah, that is what 切换. Yep. Oh yeah. Okay. Now it's okay.
Okay.
Thank you very much. Please go ahead.
Okay. Thank you very much. Sorry for today. I will talk about some of the complex congenital heart disease in adult and include truncus and the DORV and the Fontaine and the SM manager. And I mostly follow the guideline management for the ACHD. The first talk is about the truncus arteriosus. It's developed because of the failure to separation of pulmonary artery and the aorta from the fetus. So they share a common truncal valve, and the pulmonary artery give rise from the ascending aorta. And this issue generally was repaired in the neonatal period. In the neonatal period repair, the pulmonary artery was removed from the ascending aorta, and the aorta was reconnected. And after BSC repair with patch, a conduit to connect the right ventricle to pulmonary artery was established. And in adulthood, the most issue related to truncus arteriosus were the truncal valve and the diastatic conduit. And we can see after surgical repair, they generally require a conduit to reconnect the right ventricle outflow to the pulmonary artery. But my personally, I use multiplication with posterior direct osmosis and page augmentation. This possibly delay the requirement of a diastatic conduit replacement in the future. And however, so during the follow-up patient, the patient with the associated anomaly like truncal valve insufficiency, interrupted arch, or coronary anomaly, they have the more risk of the death complication. And the truncal arteriosus is quite often associated with the chromosome 22q11 deletion, so-called K22 syndrome. And so in the infant, generally we do a genetic testing. If the patient is associated K22 syndrome, it is generally associated more easy to detect death complication, including respiratory and the pulmonary artery issue. And however, the survival after the neonate repair, the survival rate generally is exceed 90% in 20 years. So it means if the patient could survive in neonatal stage repair, the patient could generally survive to adult. And in adulthood, the intervention for the RV2PA conduit is generally likely inevitable. In the statistics, more than 95% will require conduit reintervention in the 20 years follow-up. And the second common issue is the neo-aortic insufficiency, especially if the patient has already have truncal valve insufficiency in the neonate. The truncal valve in truncus arteriosus could be 3 cuspid, 4 cuspid, or 5 cuspid or even more complicated. And the defect, it could be dysplastic. So if the patient have the full truncal valve defect, it generally have insufficiency in the future follow-up. And so if the patient is develop severe aortic insufficiency after repair, the patient will require a aortic valve intervention. It could be a repair or Ozaki procedure or replacement of the ascending aortic valve. And the other issue is the new aortic dilatation. It is frequent observed, but generally it is not required to intervene. And unless the progress rapidly and accompanied by significant aortic insufficiency, if the ascending dilatation and accompanies new aortic insufficiency, generally a bento type procedure or aortic valve replacement with ascending aortic graft is required. And so in the outpatient follow-up, we can see if the patient is physiologically more severe, generally half year to 3 months follow-up is recommended. And generally echocardiography is the key follow-up tools for the truncal arteriosus. And the second topic is the double aortic right ventricle. The double aortic ventricle is a relative diversity condition of the relative primitive development of the heart. It composed of the VSD, where the VC is the sole outflow for the left ventricle, and the both arteries were arising primarily from the morphological right ventricle. But there are a lot of anatomical variations. So generally, we classify the DORV according to the relationship between the VSD and the great artery. We can find on the figure, if the VSD is located beneath the aortic valve, then the ventricle flow is mainly to the aorta, so it is physiologically similar to the large VSD. If the pulmonary artery is small, it will be cause physiologically similar to the tetralogical furrow. In contrast, if the VSD is located in subpulmonary, the left ventricle flow go to the pulmonary artery. The physiology will more like a transposition of great arteries, and we call it a tau-spin anomaly. In tau-spin anomaly, we can also do further define the patient is associated with coarctation or other kind of lesions, and the size balance between the right ventricle and left ventricle. And the VSD could be doubly committed or not non-committed. Non-committed means a significant difference to the both great artery, and it could be also called non-committed VSD. In the remote VSD, generally the trading between the single ventricle pathway or biventricular repair would be depend on individual cases. And so we can see the repair strategy also depends on the anatomy. So in the patient with sub-aortic VSD, generally we can buffer it to the ascending aorta. And if the patient do not have pulmonary stenosis, it is like a large VSD repair. If the patient with pulmonary stenosis, it could be similar to a tetralogical furrow repair. And if the patient with the pulmonary VSD, generally the more favored procedure is to rerouting the left ventricle to the pulmonary artery and do the arterial switch operation. And so the physiology could be restored to normal. But there are also some other choices like intraventricular Kawashima repair or other kind of procedure. And so the management of DRV in adulthood generally depends on the anatomical repair. If the patient is tetralogical furrow type, that follow-up is similar to the tetralogical furrow patient. If the patient requires the arterial switch operation, then it will be similar to the long-term follow-up in the patient with transportation. If the patient repair involve a rastretic conduit, then the close follow-up for the rastretic conduit for pulmonary valve stenosis or insufficiency is similar to the patient after rastretic apposition. If the patient receives single ventricle palliation, then the long-term follow-up principle will be followed. And a special consideration in the DRV is the intraventricular buffer. Because of the VSD repair is likely a connecting a tunnel between the VSD to the aortic. So if the patient was repaired in relatively early infant, then after the patient grow up, the buffer maybe become too small, and then it will cause LVOT obstruction. Or if the buffer have some leak, will become more intense after the patient grow up. So the serial echo follow-up is recommended if the patient with significant LVOT obstruction or significant leakage in the buffer, the surgical intervention is suggested. And so this is a summary of the initial DRV physiology and the surgical management option, and the late follow-up was similar to the surgical procedure in this group of patients like Fontan or TG or Faro or VSD, and with special issue on the intravesicular buffer repair, the condition of the LVOT or buffer leak or some RVOT or. And the third part is the Fontan palliation or single ventricle. The Fontan palliation initially was called the right heart bypass surgery, and Cruiser and the other surgeons, they start to perform in the patient with triatriatum atresia. So they do an assignment of the right atrium to the pulmonary artery, and then they remove the MPA or sometimes use a conduit to connect the right atrium to the right ventricle. However, all these procedures were mostly abandoned in current era, because in 1990s, the Dr. Dileva in Great Ormond Street has showed that the smooth of the venous pathway is important to avoid energy loss and could improve the outcome of the patient. So after that, the TCPC, the total compound connection, become the main treatment for the single ventricle patient. And there are two groups of the operation. One is the lateral tunnel, or called intracardiac tunnel, to connect the IVC to the pulmonary artery. And the other type is more frequently done in the current era is extracardiac TCPC. It authorizes a conduit to connect the IVC to the pulmonary artery. And in this figure, you can find that the fenestration was created between the conduit to the systemic atrium, so-called fenestration. To perform penetration or not is still under debate in various centers. Some centers routine not do penetration, and some centers routinely do penetration, and some do optional. The penetration could theoretically improve the cardiac output and decrease the systemic venous pressure, but take expense of the systemic oxygen saturation. So there are still some debate, but generally, if the patient have fenestration and desaturation in the follow-up, the closure of the fenestration is recommended. In contrast, if the patient has a very high systemic venous pressure and the decreased feeding to the systemic ventricle, create the fenestration is generally recommended by the expert opinion. The Fontan circulation is not like the other biventricular repair. It is forced systemic venous return to the pulmonary artery. So it causes the coronary hemodynamic disturbance with the increased venous pressure. So it increases the venous pressure and the lack of the pulmonary subpulmonary ventricle, cause the patient result in like a low cardiac output symptom, and also the venous congestion. The venous congestion will drive the lymphatic failure, liver fibrosis, or protein loss enteropathy, and leg edema, pleural effusion, ascites. So in the Fontan patient, if the patient develops complication, it's not only a cardiac output problem, but also a multi-organ function involvement. And we can classify into the several issues, including the circulation, the arrhythmia issue, the Fontan-associated liver disease, lymphatic issue, and others. And so the part of patient with Fontan not only require cardiologist and the ACHD specialist surgeon, and also the other multidisciplinary expert like hepatology and nephrology and the hematologic issue. And the return surveillance and testing for the Fontaine patient, not likely the other HDD, generally the echo and the EKG is the routine, but the liver imaging and the other laboratory, including the BCS, was suggested to do the annual follow-up, especially for the Fontaine-associated liver disease. If the patient already have some heart failure or liver cirrhosis, then generally every 3 to 6 months follow-up is recommended. For cardiac evaluation, generally cardiac cath for invasive hemodynamic evaluation is very important. It determines including the patient to have completion of the Fontaine ablation, or the patient have the new onset organ dysfunction. The hemodynamic evaluation should be performed with the cardiac acceleration, and the other advanced image like CT and the MR is recommended for the patient with hypoxia or hypotension. To do a CT, it should be also very important to have a timely getted some so-called cardiac CT and to pursue the contrast media to fully fill up so that we can see if the venous pathway and the pump out has thromboembolic or not. It is very important in the patient with the Fontaine circulation. If the thrombus develop and we do not treatment, it will cause the venous obstruction and also hypotension, hypoxia. If the patient has the pulmonary artery stenosis, the cardiac cath dual stenting is generally recommended to improve the hemodynamic. If the patient has a significant venous volume overload on systemic ventricle and the adult outer pulmonary collateral vessels, the cardiac cath to embolization the collateral vessels is recommended. And also, if the patient develops systemic to pulmonary venous collateral and need to cause hypoxia, and the cardiac acceleration could be performed to do embolization for the collateral to improve the patient's oxygen and the hemodynamic. And also, if the patient develops the pulmonary artery hypertension, the vasodilator therapy is recommended to improve the exercise capacity, despite the data is still relatively limited in the current era. The screen of the liver disease is generally suggested by annual imaging in the laboratory of the liver. And if the patient, especially if the patient more than 10 years after Fontaine operation, the imaging for every 6 months is reasonable for the patient. And if the liver cyst was developed, it could be regular follow-up. And the most important is to find if the patient has progressed liver dysfunction or other nodule and the development of the hepatocellular carcinoma. And the patient with Fontaine failure and the liver failure, it is an issue to do transplantation with the heart transplant only or heart and the liver simulated transplant. But they are only performed in relatively limited centers in the United States, and the outcome is still very challenging for the surgeon and the patient. So the patient should be very carefully evaluated for the patient with liver cirrhosis. And the venous pathway in the Fontaine patient is prone to thromboembolic development. So generally, the patient requires anticoagulation. If the patient with the indication for the anticoagulant, like the atrial flutter, atrial fibrillation, or previous history of the thrombus or thromboembolic disease, or the cold atrial pulmonary type of the old style Fontaine palliation, the anticoagulation with the either Coumadin or other new oral anticoagulant agent is recommended. In the patient with absence of high-risk feature, that means the patient have no thromboembolic history or other arrhythmia, then the using aspirin or use the anticoagulation medication is not maybe comparable outcome. So it could be decided by the physician itself. In the a survey, generally the patient with young age or childhood, more patients receive aspirin, and in the adult patient with Fontan, more patients receive Coumadin or for the therapeutic anticoagulation. It is similar to my personal practice. I usually provide only heparin in the patient with a child, and after the patient become adult, I add warfarin for the anticoagulation. And if the patient have suspect thrombus in the Fontan pathway, generally echocardiogram alone is not sufficient. They require either transesophageal cardiac MR or appropriate timely gated CT angiography to define the presence of the thrombus and guide the therapy. And after Fontan operation, atrial arrhythmia occurred more than 60% in adult patients, and the patient generally required a consultation with the EP specialist, like Professor Cho. And the patient with atrial tachyarrhythmia, it requires prompt reason restoration because it will decrease the cardiac output significantly. If the patient has a sinus node dysfunction, generally atrial pacing is required, and it is recommended not to do unnecessary ventricular pacing because it will impact the left ventricular function. And the patient with high degree AV block, the pacemaker is generally suggest a physiologic patient like a CRT or Hispano patient to avoid the dysynchrony. And if the surgical press, the apical patient may be suggested. And the patient with the dilated atrium may result in recurrent SVT, and the electrophysiologist may be perform the catheter ablation, but generally it is a very technical challenge because the atrial wall may be very sick and may be difficult to perform a complete scar to insulate the conduction pathway. However, it could be suggested to avoid the recurrence of supraventricular tachycardia, and the tachycardia will impact the ventricular function and decrease the cardiac output, so it requires prompt treatment for the arrhythmia. And the surgery has also role in the adult ACHD with the Fontan pathway. Like the doctor, if the patient have restricted ventricular septal defect in the single univentricular heart, then the intracardiac obstruction may be impact the cardiac output, and it could be corrected with the surgery. And the other most common issue is the systemic AV valve regurgitation. If the patient have a more than moderate systemic AV valve regurgitation, generally surgical is recommended to the patient with the preserved ventricular function and the moderate or severe AV valve regurgitation. Surgical repair or even replacement could be suggested to improve the ventricular function and avoid the elevated venous pressure. And the patient received a atrial pulmonary connection type of the Fontan. If the atrium is significant dilatation and have some arrhythmia, and the ventricular function is still preserved, then the conversion to a TC-PC pathway could be suggested, given the risk could be acceptable. And I have done several cases of Fontan conversion, and generally the patient have better outcome after surgery. And the heart transplantation may be required if the patient have ventricular dysfunction, and it would be better performed before the multi-organ dysfunction is developed. So the patient have ventricular dysfunction and no other issue to be corrected, it could be referred to specialists about heart transplantation. The VAD therapy for the Fontan patient is still under adult investigation. Require like do a left ventricular assist or add a right ventricular assist or right ventricular support device. And recently, a talk about the upsize of TCPC conduit is discussed in the patient with liver cirrhosis and the relative small TCPC conduit. The Washington group aggressively suggest that the size it could be upgraded to avoid the evasive, but the result required to be seen in the future. In the patient special with hypophytic heart and underwent the Fontaine procedure, because the new aorta was reconstructed with either a bovine pericardial patch or other prosthetic material. The new aortic dilatation is a special issue for the patient with Fontaine after node operation, and the native coronary artery could be also just risky for the ischemia. And the systemic right ventricle is more likely to have the ventricular dysfunction or AVSD dysfunction. And so the patient with hypophytic heart after Fontaine should be monitored more carefully. And the Ebstein syndrome is a result from long-term intraventricular or extracardiac left-to-right shunting, causing the high PVR and the bilateral shunting. It results in chronic stenosis and the abnormal loading condition caused to the systemic and pulmonary population. So it is also like a multi-organ dysfunction, including the heart and the pulmonary and the systemic, and also arrhythmia and the sudden death. And the recommended for diagnosis, the first diagnosis generally also require the cardiac cath for hemodynamics to calculate the PVR, shunting, and anatomical define. This stratification and the treatment strategy was similar to the other form of pulmonary hypertension, and the BNP 6-minute test and the functional class assessment is also similar to the other for the risk stratification. The patient with Down syndrome, pre-sarcoptic shunt, old age, worse hypoxia, reduced GFR, and the RV dysfunction or prominent risk factor for poor outcome in Ebstein syndrome. The PH therapy in Ebstein is require a special consideration, not only decrease the PVR, but also to require balance of SVR and the PVR, and also the volume status to avoid volume overload in the functional univentricular heart. Especially for the woman with pregnancy age, generally in Ebstein pregnancy is not recommended because of very high maternal mortality and the fetal dismiss rate. However, if the patient still decide to proceed to pregnancy, it requires multiple expert team to manage the patient. And this is another special issue for the childbearing woman. And generally, we don't strongly recommend the patient not to get pregnancy if the patient already have Ebstein syndrome. The pH direct therapy in Ebstein syndrome, the initial monotherapy, the most evidence is come from the endothelin receptor antagonist to do a initial monotherapy. And the second line generally is combined with a PD5 inhibitor. And for the triple therapy, the subcutaneous treprostinil or iloprostrate or cephalinic is not so conclusive, but maybe benefit. And because of the patient have Ebstein have right to left shunt, so prolonged IV line in the venous pathway is not recommended. And the arrhythmia is also required from cardioversion, and the exercise is generally should be limited to avoid very strenuous and competitive exercise. And thrombophilesis, because the Ebstein syndrome have both risk of bleeding and the thrombosis, so only the patient with indication the per patient should require thrombophilesis, not on a routine basis, because of the Ebstein syndrome have some bleeding risk like the pulmonary bleeding or other coagulation abnormality. If the patient require cardiac pacemaker, the intracardiac pacemaker lead or also not recommended to avoid the systemic emboli. And this is a summary of the current suggestion of these 5 issues. And thank you a lot for your attention. Thank you.
Okay, thank you, Professor Wang. Talk about the advanced therapy in this very complex congenital heart disease. Any problem and any question from the floor? It seems Professor Wang talk about the two difficult topic, and since the time is limited, so I have to close this section. And thank you, APSC give the next session, talk about the congenital heart, dark congenital heart disease, and we learn from the expert experience from all the Asia. And we thank you all join the next section. Thank you.
Thank you.
Thank you.
Thank you very much.
Thank you.